Cert Week 6. Non-rapid AFib treatments. Synchronized cardioversion for acute AFib within 48 hours. For chronic AFib, patient must be anticoagulated first. Digoxin should be held 48 hours prior to cardioversion. Medical cardioversion. Flecainide, amiodarone, sotalol. Spontaneous conversion. Calcium channel blockers, beta blockers, and digoxin slow ventricular rate to promote spontaneous conversion. Rapid AFib treatment. Ventricular rate is greater than 100. Stable AFib, patient is tolerating rhythm, treat with amiodarone or cardizem. Unstable AFib, patient is uncomfortable or not tolerating rhythm, cardiovert. AFib and aflutter lifestyle. Prevent thrombus, use CHADS 2 score to determine stroke risk and the need for anticoagulation. Patient teaching Coumadin diet and precaution. Bleeding, medication interactions, vitamin K, antibiotics, herbals. Warfarin for 4 weeks before cardioversion. Stroke recognition education. Goal heart rate at rest is 60 to 80 beats per minute and 90 to 115 beats per minute with moderate activity. AFib and aflutter causes: age, pulmonary disease, valve problems, congenital heart disease, CABG, congestive heart failure, coronary artery disease, MI, rheumatic heart disease, hyperthyroid. Anticoagulation based on the CHADS 2 score. Score, risk, anticoagulation therapy, and considerations. 0 is a low risk. Anticoagulation is aspirin daily. 1 is a moderate risk, aspirin or Coumadin, aspirin daily, or raise INR to 2 to 3 depending on factors such as patient preference. 2 or greater is moderate or high risk. Coumadin, raise INR to 2 to 3 unless contraindicated, clinically significant GI bleeding, inability to obtain regular INR screenings. Aflutter treatments. Treat the underlying cause. Synchronized cardioversion. If patient is in aflutter longer than 48 hours, TEE needed to assess for thrombi first. Ablation. Ablate the extra SA nodes. Medical cardioversion. Antidysrhythmics, flecainide, sotalol, amiodarone, etc. Spontaneous cardioversion. Calcium channel blockers, beta blockers, and digoxin. Supraventricular tachycardia, SVT rate is greater than 150 beats per minute. The QRS is normal and the ST depression is usually present from demand of ischemia. Symptoms are chest pain, hypotension, change in level of consciousness. The goal is to decrease heart rate by vagal maneuver. Adenosine, give fast, causes a sinus pause, or cardioversion if unstable. First degree AV block, PR interval longer than 0.2 seconds. Causes are ischemia, scar tissue, inflammation, amyloid, sarcoid, Lyme carditis, endocarditis, atrial stretch, electrolyte imbalance medications such as digoxin, calcium channel blockers, and beta blockers. Mobitz 1, Wenckebach. Risk factors are inferior MI, coronary artery disease, aortic or mitral valve disease, atrial septal defects, medications such as digoxin, beta blockers, calcium channel blockers, and conditions that impair cardiac perfusion or stimulate parasympathetic tones. Nursing assessment. Symptoms. The patient is usually asymptomatic unless they are bradycardic. Symptoms of decreased cardiac output are lightheadedness, activity intolerance, shortness of breath, chest pain, and syncope. Treatment. Pacemaker if the patient is symptomatic. Atropine can increase the heart rate if the patient is bradycardic, and medication adjustments if that is the underlying cause. Mobitz 2, dropped QRS. Causes are His-Punchki system disease, which can progress to complete heart block. Risk factors are anterior wall MI, rheumatic heart disease, and coronary artery disease. Nursing assessments. Symptoms are activity intolerance, syncope, shortness of breath, chest pain, nausea. Signs are hypotension, diaphoresis, and pauses in pulse. Tests are ECG for diagnosis, electrolyte and medication levels, EP studies to identify high-degree blocks. Treatments. Cardiac pacing to avoid progression to complete heart block. Transcutaneous pacing until a permanent pacemaker can be placed. Avoid atropine. It can progress to a complete heart block. Medications until a permanent pacemaker can be placed are dopamine and isoproterenol. Emergency heart rhythms. Third-degree heart block. Causes are rate-reducing medications, coronary artery disease, MI, valve surgery, congenital, patients with second-degree type 2, hyperkalemia, and digoxin toxicity. The assessments are activity intolerance, syncope, shortness of breath, chest pain, diaphoresis, and nausea, bradycardia, hypotension, and poor perfusion. The tests are digoxin levels, electrolyte levels, echocardiogram for cardiac function, and EP studies to assess the condition. Treatment. Permanent pacemaker used transcutaneous pacing if the patient is symptomatic and waiting for permanent pacemaker. Avoid atropine, dopamine, and isoproterenol for acute management while waiting for pacemaker. Hold medications that slow conduction such as digoxin and antidysrhythmics. VTAC. Sustained is longer than 30 seconds versus non-sustained is less than 30 seconds. Monophoric versus polyphoric. Prognosis is worse for polymorphic. Causes are hypoxia, ischemia, MI, cardiac surgery, hypokalemia, hypomagnesium, acidosis, digoxin toxicity, psychometric agents such as caffeine, nicotine, cocaine, untreated PVCs. The treatment is synchronized cardioversion for VTAC with pulse. Amiodarone can be used in conjunction with the cardioversion. Defibrillation for VTAC with no pulse, epinephrine or vasopressin, then followed by amiodarone or lidocaine. Implanted ICD, the implantable cardioverter defibrillator, or a life vest while someone waits for an ICD implant. VFib is coarse versus fine. Fine is less responsive to treatment. Cause: heart disease, MI, hypomagnesium, blunt chest trauma, hypoxemia, structural heart disease, prolonged QT intervals, acidosis, drug toxicity such as poison and antidepressants, electrocution. Goal is resuscitation. The treatment is CPR and defibrillation, epinephrine or vasopressin, then followed by amiodarone or lidocaine. An EP study and an ICD after resuscitation if situation was not due to a treatable cause. Asystole is not a shockable rhythm. Sudden cardiac death. Cardiac death 60 minutes after onset of symptoms. The causes are coronary atherosclerosis, 90% of the cases, abnormal coronary arteries, heart failure, myocarditis, valvular heart disease, congenital heart disease, VTAC, VFib, prolonged QT syndrome, dissecting aortic aneurysm, cardiac tamponade, pulmonary embolism, electrolyte imbalances, systemic disease such as sarcoidosis, amyloidosis, and hemochromatosis. Prior to death, the chest pain, dyspnea, palpitations, hypotension, dysrhythmia, loss of consciousness. Treatments are CPR, ACLS protocol, and hypothermia after resuscitation. Pulmonary hypertension. Pulmonary artery mean pressures is above 25 millimeters per mercury at rest or above 30 with exercise. Diagnosed during a right-sided heart catheterization. The causes are unknown as primary and secondary cardiac disease or lung disease. Symptoms are dyspnea, fatigue, syncope. Signs are split S2, S4 sound, murmur, hepatomegaly, ascites, peripheral edema, clubbing, and cyanosis. Treatments are heart, lung, or lung transplant or medications like digoxin, diuretics to decrease venous congestion, calcium channel blockers is the first line of drug, pulmonary vasodilators, and warfarin for patients at high risk for thrombus development. Carotid artery disease. Lesions in carotid artery. Major risk factor for stroke. Symptoms are TIA, CVAs, vestibular basilar symptoms like dysarthria, aphasia, vertigo, syncope, congenitive defects, and diplopia. Signs are carotid bruise, diminished or absent carotid pulses, blood pressure difference between the arms of more than 10 millimeters per mercury. Treatment is carotid endocardiectomy, carotid stenting depending on the location and size of the lesion. Medications are antiplatelet therapy such as aspirin or warfarin. Teaching: the risk factor modification, diet, exercise, weight reduction, smoking cessation, stress reduction, and TIA CVA recognition. Aortic aneurysm, abdominal versus thoracic, ascending versus descending. Causes are atherosclerotic lesions, inflammation, trauma, connective tissue disorders such as Marfan's or Ehlers-Danlos syndrome. Complications: rupture, thrombi formation, compress neighboring organs, and can be painful. Symptoms of an unruptured AAA: abdominal pain, dull back pain, visualized or sense abdominal pulses when patient is recumbent, weight loss and nausea from abdominal involvement, palpable pulsatile mass in the upper abdomen, Brewy Herd over aneurysm, and hypertension. Signs of a ruptured AAA: descending AAA, extreme knife-like posterior pain between the scapula, hypotension, syncope, tachycardia, shock, cold, clammy. Ascending AAA, extreme knife-like anterior chest pain, hypotension, syncope, tachycardia, shock, cold, and clammy. Treatment: a graft if larger than 4 centimeters. Keep the systolic blood pressure between 110 and 120 while the patient is waiting for surgery. Medications: hypertension medications, lipid-lowering drugs, and glucose-lowering drugs. Upper extremity arterial occlusion disease, artery stenosis from atherosclerosis or other conditions such as trauma, embolism, inflammation, or congenital. The assessment is recent trauma or invasive procedures, diminished or absent pulses, color changes, Brewy's, Addison maneuver, and Allen test. Dopplers and arteriography is used for testing. Treatments are treat the cause: embolectomy, repair of the trauma sites, arterial bypass procedure for the proximal arterial lesions, endocardectomy to remove the plaque, or medications such as fibrinolytic therapy, anticoagulation with heparin or Coumadin. Treatment of vasospasms with channel blockers. Lower extremity arterial occlusive disease, artery stenosis from atherosclerosis, most common cause, trauma, emboli, or compartment syndrome. Common sites are iliac, femoral, popliteal, tibial, and pedal arteries. Symptoms occur distal to the blockage. Risk factors are atherosclerosis, which is most common, trauma, smoking, age, being a male, diabetes, hypertension, high lipid levels, and family history. Assess is pain, color, and temperature changes of the limb. Acute: pain at rest, absent or dim pulses, paresthesia, tissue necrosis, paralysis. Indicates irreversible ischemia. Chronic: intermittent claudication. The pain resolves with rest. Dependent color changes. Dusky when dependent. Pale when elevated. Arterial ulcers, tissue necrosis, dim and absent pulses, and cool temperatures. Testing: ankle brachial index, Doppler, and arteriography. Treatment: acute: embolectomy, arterial bypass, or amputation. Chronic is angioplasty or stent, endocardectomy to remove the lesion, bypass, or amputation. Medications: thrombolytic therapy, antiplatelet therapy, drugs to reduce risk factors such as hypertension, lipid-lowering, and glucose-lowering medications. DVT. Risk factors are stasis, age, immobility, heart failure, hypercoagulability, coagulation disorders, pregnancy, oral contraceptives, malignancies, endothelial injuries such as trauma, intravenous catheters, and peritoneal medications. Symptoms are pain, swelling, increased temperature of affected extremity, color changes, edema, asymmetry of legs, positive Holman sign. Tests: venous duplex, venography, serum coagulation tests. Treatment: thrombectomy, inferior vena cava filter, anticoagulation with heparin and Coumadin for 3 months, Xarelto, and a fibrinolytic therapy. Education: risk factors, the compression stockings, elevation of affected extremities, and signs and symptoms of a pulmonary embolism. Chronic venous stasis. Causes are obstruction, such as tumors, fibrosis, or infection, valvular insufficiency, such as varicose veins, valve prolapse or incompetence, or calf muscle pump malfunction from muscle wasting and muscular fibrosis, or MS. Risk factors: family history, age, female, occupation, obesity, DVT history. Assessment: pain, spider veins, tortuous veins, hyperpigmentation of feet and ankles, lipodermatosclerosis, venous stasis ulcers. Treatment: varicose vein stripping, venous bypass, sclerotherapy, injecting the substance into the veins to create scar tissue and eliminate the venous lesions. Education is signs of infection, dressing changes for the ulcers. Compression stockings to avoid prolonged standing. Elevate legs when seated. Wear loose clothing. The Uno boot for ulcer management. Uno boot. Patient must ambulate to increase compression and promote circulation. The patient should elevate the leg with the boot above the level of the heart for 10 to 15 minutes, 2 to 3 times a day. Non-ambulatory patients should not use an Uno boot. Patients should report any numbness, tingling, and pain. Venous ulcers are shallow and irregularly shaped, and arterial ulcers are deep and punched out shape. Arterial versus venous. Arterial cause is insufficient blood supply to the area, causing ischemia or tissue death. The risk factors are vascular insufficiency, uncontrolled blood sugar in people with diabetes, limited joint mobility or mobility problems, and improper footwear. The characteristics are punched out appearance, smooth wound wedges, pain at night and relieved by elevating the leg, usually occurs on the lateral foot but can occur anywhere on the lower legs. Lower extremities are cool to the touch, pale, shiny, thin skin, minimal to no hair growth, and minimal drainage from the wound. Venous causes pooling of blood, causing increased pressure in the vein. The risk factors are varicose veins, deep vein thrombosis, incompetent valves, muscle weakness in the legs, immobility, pregnancy. Characteristics are shallow and superficial, irregular shape, painful from edema, phlebitis, or infection, and usually in the lower legs or ankles. This is week 6. Thank you.